So it's my pleasure to introduce Dr. Wei-Leong Go, who I've had the privilege of knowing for many, many years. And Wei-Leong, many of you will know as the ICMDA Regional Secretary for Southeast Asia. He's based in Singapore. But that's just what he does for ICMDA. He's a general practitioner and the founder and director of Linking Hands, which is a medical networking agency connecting Christian medical professionals and students to short and long-term opportunities, crisis relief, and student elective programs. He also chairs the Christian Medical and Dental Fellowship of Singapore, which is an ICMDA member body, and is involved with the Medical Missions Foundation, which raises funds for doctors and dentists in the field. He has helped found and chairs a not-for-profit company called HealthServe Limited that reaches out to the fringe communities of foreign workers and commercial sex workers. And as you'll see, there's no one I can think of better qualified to talk about serving migrant workers cross-culturally in a resource-poor situation. So Dr. Wei-Leong, it's a pleasure to have you, and we look forward to hearing your talk. Thank you.
Thank you, Peter, for the kind introduction. And hello, everyone, and good to see so many names of folks from around the world. So the topic today is serving migrant workers. And the aim of this webinar is to draw upon Jesus's example in the Bible through the use of some of the Bible verses and stories we know. At the same time, I'll be sharing with you some of my own personal journey. But before we go into the slides and the webinar itself, I'd like to give you a little short video to give you the context of what the world is like in the world of migration and migrant workers. So could I have the video, please? So this video gives us a glimpse of what's happening around the world of migration. And it does give us a very good context. And today, as we talk about migrant workers, which is a real global phenomenon, I'd like you now to spend the next minute or so to think about migrant workers in your context. Think of migrant workers who might be just in your neighborhood or in your cities. Think about them who are working in food and beverage or in factories or down the street where you live. Now in the US, perhaps, you may have got migrant workers from Mexico and Latin America, and they are an important component of the agricultural and construction labor force. Or if you're in Europe today, you'll get migrant workers perhaps from Eastern Europe, maybe Romania, Bulgaria, or even Poland, or maybe from some North African countries like Morocco, Algeria, Tunisia, and others that contribute much to the agricultural labor force. In the Middle East and also in Singapore, migrant workers from South Asia are important in the marine, construction, and process sectors. So almost every country, developed or even developing, relies on migrant workers and migrant labor in one way or another. So what then are some principles that we can learn from Jesus's example and teaching so that we can minister to migrant workers? Next slide. I'd like to propose that we think of serving migrant workers with a framework like so. I've got 3 frames. The first one, serving through medical, social, and personal. So the first one in medical, we see Jesus as healer. In the social frame, we remember that Jesus knew people in their context. And the last frame, which is a personal frame, Jesus sought to know people through very intimate conversations. And so we'll use this as a framework for tonight's or today's webinar. Next slide. So Matthew 15:30 talks about great crowds that came to Jesus, bringing the lame, the blind, the crippled, the mute, and many others, and laid them at Jesus' feet. And guess what? He healed them. So being physicians and healthcare workers, we have a powerful and very relevant, much sought after skill, a God-given skill. And this ability to heal. We provide medical care to migrants, which is very highly likely in our context, in a powerful way, as well as to reach out to them. It allows us to meet their needs when they are in pain, when they are overwhelmed with worry, and when they are seeking hope. You see, migrants in their host countries are often left out of the formal healthcare system. Universal healthcare systems generally do not include migrant workers. Migrants are often not able to afford or have access to private healthcare services, like in the US, and sometimes in many other countries too, largely due to the very high cost of medical care. And in Singapore, we saw that need in HealthServe, and we responded. And tonight, or today, I'll give you a glimpse of some of the things we've done, a little breeze of the stuff that we've done. Next slide, please. So we saw this need and started with a clinic. Now, our clinic was largely founded by CMDF or ICMDA Singapore doctors some 15 years ago. We registered it as a secular NGO, and we are run largely by volunteers. We've got 100 over doctors who are on our volunteer list and some 600 active volunteers. We also take medical students, and we run a module with the Family Medicine Department in the National University of Singapore. And the HealthServe clinics is generally a GP clinic, and we also run specialist clinics like orthopedics and dermatology. Again, all run by volunteers. We have a chronic disease clinic as well as dental. And in fact, dentists are the most sought after people in the HealthServe context because dental care is one of the most pressing needs among low-wage migrant workers. Of course, alongside with orthopedic and dermatology. So how else did we respond? Next slide. So with the clinic gave us a platform to shape the landscape of medical care for the migrant workers, which was almost very non-existent or at the fringe. Volunteers, being the backbone, were able to express their gifts and their passion. And in this slide, I've just shown you something which our young doctors did as they were introduced to the issue of migrant workers and the struggles they have. So these 2 young doctors, Joanna and Dennis, were very into the issue of migration and migrant workers, and they had volunteered with HealthServe. And after the stint, and after knowing what happens in the sector, which was quite new then to the Singapore public or the medical fraternity, they wrote out a guide for Singaporean doctors at the emergency department, because in those days, the emergency department did not know the context or the struggles of migrant workers who were from a different culture, a different country, spoke a different language. And this slide shows the article by the Singapore Medical Association talking about this standard operational practice piece written by Joanna and Dennis. Now, HealthServe now is in the Ministry of Health, workflow involving local ministries and some of the healthcare systems. Next slide. Now, the clinic then also showed that we needed research because we needed evidence-based practice. And what's best practice? And so HealthServe had volunteers who did research. We did research like a paper on health-seeking habits of migrant workers. We even did one on TB prevalence or latent TB prevalence. And really, we really needed this evidence-based because we needed it to guide our actions and how we structure the services we provide. Because we didn't know enough of migrants. This work is always work in progress. And we're proud to say that a couple of our research papers have appeared in pretty good journals too. So active engagement with research, with authorities, have put us in a good position. Next slide. How else did we respond? Well, from a clinical point or medical point of view, COVID, I'm sure most of you, in fact, everyone is deeply involved with COVID. Well, we had our own share of the COVID response. COVID having exacerbated the inequalities really made evident how much migrants were disadvantaged and excluded from the local healthcare services, especially in Singapore. The workers' journey was one of emotional and mental challenges. And some of the challenges included things like confusion, frustration, a lack of clarity, in fact, even shame, because many of the migrant workers felt guilt and shame for not being able to provide for their families back home where they came from. They were unable to send money because they lost their jobs and their families back home had no food. And then it resulted also in mental health issues. So what we did was also to have tele-collaboration services. We had telemedicine. So our main clinic started having telehealth doctors. We have to date some 35 telemedicine or telehealth doctors. Apart from that, we distributed healthcare packs and we had financial assistance. And during the lockdown in Singapore, the migrant workers who were locked down in the dormitories and unable to get out were then given also lots of other help like food and other basic necessities. So there were three basic or direct interventions with our stakeholders. The first direct intervention was engagement with hospitals. We engaged the major hospitals in Singapore. We also engaged government agencies. We helped with posters and translations of COVID, for example, into various languages. We provided PPEs and we had health education on hygiene practices and all. And on-site, hospital teams were given some extra help from our volunteers to understand the context and cultural context of migrant workers. The other direct engagement with HealthServe did was with workers at dormitories. We conducted discussions with them. We were the ones who helped bridge the language communications and we bridged the communities. Patient education was also done at dormitories and many of the quarantine facilities. And we had morale boosting programs and we responded to distress calls and a hotline was even set up. An intervention was given through telecounseling and tele-befriending. So we had virtual telecounseling services. Teams were set up within a couple of weeks, and we had remote group session and therapy sessions. And of course, the last direct intervention, again, was direct counseling, as mentioned. And apart from that, we had joint media productions also to come up with health videos, and we did it with NGO groups. Next slide. So ICMDA is not the only one who conducts webinars. We did it during COVID, and this was one of the webinars that our CMDF and health service doctors conducted. We teamed up with other NGOs, and we had interview with the major Singapore TV channels and also news and media. Next slide. And these are some of the things we did. Some of our doctors and our volunteers provided haircuts for the migrant workers when they were in quarantine. And we handed out food packets, and even for some of the workers, we gave them a small, some financial assistance. Next slide. As mentioned, mental health during COVID-19 was a huge, huge issue. And our psychiatrist, who is our board member and doctor at HealthServe, wrote this paper with our medical director on the mental health issues we face during COVID. So really, how can church, how can Christian medical health workers be that faithful presence of love in the absences of social and community life during COVID? That's a big challenge for all of us. The next slide, please. So the second framework that we use is the social framework. So Jesus knew people in their context, and that's really key, isn't it? Now, there's no end to helping migrant workers. As Christian healthcare workers, we have an additional mandate. We want to reflect Christ in our lives to the people around us. We want to be a faithful presence of love to the people, to migrant workers in their context. And oftentimes, right, the better we know them, the better we relate to them, the better we understand their worldviews, the deeper the connection and relationship. So we need to know what their lives are like. So at HealthServe, we have volunteers visiting dormitories, we appreciating their lives that they live, which is quite different from the average Singaporean. With HealthServe staff visiting their, also even before COVID, visiting their hometowns in Bangladesh or even in China to understand their context. And understanding their context has helped us shape the way we practice. Next slide. One of our beneficiaries, a migrant worker called Kauza, he had his 3 fingers amputated because of an industrial accident. We ministered to him for a few months, and then he went back to Bangladesh. And guess what? He ministered to his own people in their context. He hasn't openly come to faith yet, but yet we believe that he's very close to it. In fact, Kauza come back to Singapore and worked amongst his own people in another NGO. So really reaching out to people in their context is key. Next slide. And now I'd like to read, to give you a little time to think about how important cultural contexts are. We had taken our medical students for part of their exposure to migrant work. And in their reflection, this is what one of them did. This student painted, as part of a reflection, a painting reflecting her time in HealthServe. And let me read what she wrote to explain this painting. I have just completed a painting as my HealthServe reflection. In the painting, I drew a migrant worker sitting on the ground between 2 alleyways. He is illuminated by a dreamy colored lights of the city. The dark alleyway contrasts with the beautiful or colorful city lights and shows how far removed the worker is from the city dwellers. The dreamy hues of the city scale reflects how they ultimately come here because they have dreams to chase. The worker reaches out to touch a silhouette of this young son. The boy is not there, and the silhouette is merely a manifestation of the worker's memories and longing for his family. The silhouette of the boy is painted in the same shades of purple and blue as the city, symbolizing how ultimately many of them dream of providing a comfortable home for their family. Family and dreams are common themes I have found while talking to the workers. Really, these themes are common to all, and I wanted to capture that. Thank you for giving us the opportunity to interact with the workers and see the beauty and tragedy of our common humanity. This is the painting by a third-year medical student. And let's go now, the next slide, to the last frame that we learned from Jesus, how being personal is important. Jesus sought to know people through intimate conversations. And with that, I'm going to take our cue from Luke chapter 24, verses 13 to 35, the story from the road to Emmaus. Next slide. So in this lesson from the road to Emmaus, in Luke 24, we see that Jesus walked the journey with them. Jesus spent time and effort with the two disciples along this road. He listened and was attentive to these two disciples. And Jesus shared truths with them. He lived with them. He ate with them. So really, we learn from Jesus that to know people intimately is to share life with them, doing simple, if not sometimes mundane things, such as walking alongside, eating and living. And along the way, talking and sharing truths. Next slide. Some of the things we've done at HealthServe is cooking and community around the table. And this shows a photo of some of our migrant workers cooking with our volunteers. And you know, food is such a deep connection. And the only problem now is that with COVID has made social gatherings a very, very big challenge for us. The next slide. So HealthServe collaborated with the National University to research on the health needs of Bangladeshi workers. And what we did was we had conversations with 8 to 12 workers using a culture-centered approach. And based on the conversations with the workers, they said that food was really very important. So food emerged as a health issue for the workers. And so the research team decided that, well, this was going to be the research project for the next 1 or 2 years. And we did this 2-year research. Next slide. We realized that truly the ground knows best. And research was addressing the issue of food. And despite, one of the things we found that despite the findings that we have, the change that we wanted did not come easily. And you can, privately sort of email me and I'll tell you some of the lessons we learned. It was a very difficult lesson that we did. So the key point is that we may know the issue, but the migrant workers themselves know the whole story. And that's really important as we serve them. Next slide. So this is something about the research that we did. Next slide, please. And finally, apart from food, cricket and community goes hand in hand, isn't it? Knowing people intimately includes exercise and games. And in cricket, most South Asians were teaching us Singaporeans how to play cricket. If you look at the slide on the right, you'll see folks doing exercise. Now that happened in the cruise center. Some of the migrant workers were doing their quarantine in cruise ships. And that is not a nice love boat scene. It is a very painful time because of quarantine in a cruise ship. We had volunteers going there to do exercises with our migrant workers on board. And you know, migrant workers, although they have very laborious jobs, they suffer from poor health due to very often unhealthy diets. And because there just isn't enough money to have a good diet. So exercise would be very beneficial to them. And exercise and activities can also be that point of connection within us and migrant workers, and to break down barriers and to forge new bonds. Next slide. So in summary, serving migrant workers in HealthServe included the medical and dental care, casework, social assistance, counseling, mental health programs, advocacy, and education. Yet these are only life-giving when framed with Jesus's framework of medical, social, and personal frameworks or components. So we must remember that Jesus was a healer. He knew people in their context, and he sought to know people intimately through conversation. And the last slide. So serving migrant workers, we must be a faithful presence of love in the absences of this world, in the absences of justice, and love and grace. We can be the ones to bring hope when there's despair and love where there is no love. So serving our neighbors, being a faithful presence of love in the absences of the world is something that we can do serving migrant workers. Thank you.
Dr. Wei-Leong, thank you so much. Beautifully comprehensive whole person medicine approach, the healthcare, the personal care and the social care all together in the model of the Lord Jesus Christ. So let's move into the questions. And first of all, could you talk a little bit about the support given to illegal migrants? We know many migrants are there legally, but others will be there illegally and in fear of the authorities. Do you provide care to these folk, and what kind of support are you able to offer them?
Well, thank you for that question. Now, it's a very interesting question because in Singapore, the context is really that we have very few illegal migrants. All migrant workers in Singapore, low-wage migrant workers, are all legal. However, when they get injured, they are given a pass called a special pass that allows them to stay so that their case can be settled. And that's the time where they need most help. So unlike many other countries, we have hardly any illegal or workers without permits. So most of them come with permits. I mean, in terms of context, we've got the population of Singapore is about 5.7 million, and we've got about 1 million low-wage workers. Now it's probably about 800,000 or so. And so the construction workers will be about 200,000 or 300,000. And so out of all these, there are very few who are illegal. Now, for those who are on a special pass, we provide them with legal advisory. We've got folks and casework. So, when we started, it was a clinic, and largely because most of our doctors were CMF doctors or CMDA doctors. But very soon we realized that apart from medicine, to be holistic, many of the workers had legal issues and social issues, and we had to work with lawyers and social workers. In fact, today, the medical component would be less than 50% of the work. Most of the work, you'll be surprised, is actually advocacy, research, social casework, and some legal casework. And we've got lawyers who do pro bono casework for us.
How are the health expenses covered? Is this treatment that you're giving offered free to people, or do they have to pay for it? And how, I guess that's tied into the question of how you fund your ministry.
Well, So for the migrant workers, because they are to pay private rates in the Singapore system, and this is to be taken care of by the employers. But however, many employers do not want to pay for the medical treatment of migrant workers. Now, this is a Singapore context. So the migrant worker will have to pay the same rate as a tourist from the US or a private patient. So they are not subsidized from the national health care schemes. They're excluded from that. And so because of that, many of them do not seek treatment because of costs. Now at HealthServe, we charge them $8, which is in a Singapore context, a very low rate. It's a token sum. And if they've got no money, they don't have to pay. We do dental for the same thing, very low cost. Again, if you tell us that you can't pay, we don't charge you. So that token fee is very important. I think it gives dignity to the migrant workers. And we have got instances where migrant workers offer us more. They say, look, this is so reasonable. Could we help others by giving you more? So we are so thankful for that. The good thing, the latest last week, just a week ago, the government came up with a surprise news that they are having 6 designated clinics offered for migrant workers. And they've invited large groups to be a part of the a scheme to treat migrant workers, a healthcare system specially catered for migrant workers. So we are thrilled at HealthServe that the public and the government now is proactive in meeting the healthcare needs. And this is a real, a milestone that we are celebrating.
And how, you mentioned that you've got 100 GPs working with you.
That's right.
And you've got 600 volunteers, I think you said.
That's right.
How much time do these folk put in, and are they paid for their work, or do all of them give their services voluntarily?
So in the HealthServe context, again, we have one medical director and he's paid, and everyone, we've got one medical director, 2 clinic managers, and everyone else who does the medical work are all volunteers. Okay. So the doctors would spend typically either once or twice a month on the roster. The dentist sometimes once or twice a month. So they'll come, and the really enthusiastic ones will do it weekly. And we've got medical students, pharmacy students, nurses, housewives and engineers all coming to volunteer. Now, COVID posed a special challenge for us. Overnight, we lost 90% of our volunteer pool because, again, many of doctors were unable to cross institutions. So that left us with barely 10 doctors. And because of that, we had to pivot right away to telemedicine.
Okay.
Within about a week of COVID lockdown.
Yeah. And I guess in Singapore, that would be easier than most places, given your facility with IT. Did you have most of the structures in place already, or did you have to develop new technologies to do that?
Well, we did a hybrid system. So I was one of the first to test it out. We have IT volunteers come, set up Zoom, and I used an iPad, and there was a final year medical student who was on site, and there was one doctor on duty, and I think 1 or 2 medical students were running the clinics for us. So they were seeing the patients, and I was at home, and we had a phone, a mobile phone, an iPad, and a desktop. And so we used various devices to do the telemedicine. That was just the start of it, yes.
Yeah.
So we did, hybrid
approach. So that's a huge number of volunteers involved in what is a relatively small country. I know that the CMDF is very strong in Singapore, but how did you go about recruiting these GPs and medical students and other volunteers? How did they learn about your work and want to get involved, and how actively did you need to look for them as opposed to them coming to you?
Well, I did very little. All I did was to feed them. I invited them for meals. for tea, for dinners at my house, for parties, and they came. So that's one trick you could use. Having said that, you see, when we had a core of CMDF doctors, they invited their friends, you see. And now we have got a huge pool of people, both Christian and non-Christian doctors. And it's a wonderful community where people come and serve together, people from different faiths, within a context of a secular NGO that was built and founded on Christian values. And so again, we've got people, again, not just doctors, but volunteers from other faiths joining us, serving migrant workers.
Can you tell us, many of the people coming to you would have just needed primary care, but others would have needed referral for hospital, inpatient investigation or treatment as well.
That's right.
What sort of roadmap do you have to connect people either to mission hospitals or to other hospitals within Singapore, and how does the funding work for that?
So funding, yeah, I think I forgot to mention that. So funding, we started off with just getting friends of CMDF, largely that, and the first few years was that, but as we grew, funding was a problem. So I then had to approach foundations, and then as foundations came, because we are not funded by the government, you see. So I did active fundraising. We then involved people from the banking sector, and because the awareness grew for migrant workers, and so the funds started coming in, and the Lord just blessed us with funds. We were never in need, and the Lord always provided. And so back to your question about the workflow. So yes, we are primarily a GP clinic, but then our most active specialist clinic is dermatology. We have lots of contact dermatitis, occupational related problems. And we've got dermatologists who run the specialist clinic once a week or twice a month. And orthopedics is also important because many of the work injuries are orthopedic injuries, and assessments and advice have to be given. We've got physiotherapists and occupational therapists doing the rehab, volunteer, they do pro bono, they do rehab for the patients too. So there's a whole network. So it's largely our network. Now, if a patient comes with a foreign body in the eye or eye problem, then we have got a list of doctors, of ophthalmologists who are friends of HealthServe, whom we send the patients to. And very often our friends will charge them. The charges are very, very nominal, and very often it's free. And so, and as the doctors do that, they tell their friends, and the other specialist friends say, hey, count me in, the next time you need a specialist referral, send them to me. So I think it's just a network, informal network within the country.
Yeah.
It's an informal network of friends of HealthServe. We have got, sorry.
Yeah. No, carry on.
So with, for example, we had a neurosurgeon who actually gave free, there was a worker who had a very serious back problem and injury. And the neurosurgeon did this $10,000 operation without charging a fee. And all the patient did was to pay for hospital, the bed space and hospital stay, but his surgical fee was all waived. And we have many of our surgeons who do that.
That's amazing. How often do you find that the migrant workers are themselves Christian believers and evangelizing the local population?
Christian migrant workers are few and far between. We have a few South Asians who are from India who are believers, and they've been amazing. They're the ones who share the good news with their own fellow people, fellow countrymen. Of course, we don't have many from the Bangladeshi community, but amongst the Chinese community, Chinese migrant workers, many of them discover the faith, discover Jesus, and then they share the good news among themselves. So at HealthServe, we do not encourage the doctors to proselytize because we live in a multi-faith. We embrace and we celebrate this community we have. But we are clear about who we are as Christian doctors, those amongst us in health service who are Christians. But we don't do direct evangelism. We are integral in our faith. We do integral mission. And for many of the migrant workers who have come to faith, it is their fellow newfound believers, right? The new believers who share the faith with them. And very often they will come ask me or ask others, hey, tell me, doctor, why are you helping us? And that gives us the opportunity to share why we do what we do.
Yes.
So it happens all the time. So we don't actively go out to do direct evangelism because we feel that we have to earn the right and the friendship and relationship. And then they ask, because they're reading us all the time as we serve them through medical practice.
Yeah, so I understand that. So you don't actively share faith within the context of a medical consultation, but if people come and ask you,
that's right,
you would be free to. But how about the work that you're doing that's more directed towards social needs or personal support or friendship? Does that give opportunities for sharing of faith in Jesus?
Oh, absolutely. I mean, social context, being, helping and expressing our faith in good works has been fantastic because for many of the migrant workers, we at HealthServe are the few people who call them by name. We sit together, have a meal with them, and they are our friends. And, we help them with their social, mental, and emotional, and even spiritual needs. And, we see every one of them as fellow humans. Is that dignity. In fact, HealthServe's vision is to see a society where every migrant worker lives a life of dignity. And this dignity has a basis in the belief that everyone is made in the image of God. And all the migrant workers, every patient we serve, are people made in the image of God, even though they may not acknowledge the Maker himself. And so with that lens, it has given us that, the deep connectedness and love for those who are not like us and yet made in the image of God. And so we have the opportunity to be a faithful presence of love to them through our social work, and they know it. When we give them a drink, we give them clothes, we find shelter for them. When we bring them to the specialist, when our fellow specialists, Christian specialists, doctors, give them a waiver of the fees. When we send them to the airport, the little things, or we call them and talk to them, ask them about their family, that blows their mind because in most instances, they are forgotten.
Now, I was fascinated by your mention of the government starting to open a series of clinics for migrant workers after some time. I was going to ask, what sort of relations do you have with the government? Are they happy about what you're doing? Are they aware of it? Has there been much opposition to you doing this work?
I think it's a wonderful question. And, many people around the world will ask, so does the NGO work with the government? Well, yes. So when we started the work, we were a little GP clinic and we, started a small clinic, meeting patients at the very, downstream. And then we realized that, hey, look, in order to change, we need to affect systems, right? We need to go upstream to engage actively with government. And that was also one of the reasons why we decided that evidence-based practice is important. So what we did was research, and then with the research, we go to the government, the Ministry of Manpower, Ministry of Health, and say, hey, look, sir, this is what we are experiencing on the ground. These are the struggles of migrant workers. And this is our findings from our research. Can we talk? And they listen to us. And active, constructive engagement with government is key. And in advocacy, we have avoided adversarial advocacy, but we practice what we call relational advocacy, meaning to say, help me understand where you come from. And when we approach with a posture of learning and humility, it really breaks down walls, and government officials are much more willing to engage with us. In fact, they are very supportive of what we do, and we are very thankful for that.
Can you give us some examples, Wei-Leong, of the sort of advocacy that you've done with government to better address the rights and the needs of migrant workers? Any specific areas where you've been able to advocate relationally?
Sure. So one of the more serious things that happen is when migrant workers get injured. So when they're injured, there was, they are due to get compensation and all. And one of the things we have done is to speak on behalf of the migrant worker. Many of them would see some unscrupulous specialists, for example, who are working in cahoots with the insurance companies. And so they would then, give sometimes medical leave or compensation that is way below what's expected. So then we find that workers come to us and plead with us, and we then go to the government and say, look, we need more legislation on some of these, the health in terms of enforcement and even regulation, and they have done. And they've sent regulators, they've done investigations. Another one was legislation in terms of work safety, working hours. We've had conversations and meetings with the Ministry of Manpower, Ministry of Health, and they've been very proactive, and we have seen some legislative changes to this, and we are very thankful. Now, of course, the latest one is that the government saying that we need to have comprehensive health care, primary health care dedicated for migrant workers. That is one of the biggest wins we've had in terms of the years of advocacy, telling them, hey, look, we really need to look into primary health. And that's really the cornerstone of the health of workers. We owe them this, as medical professionals.
But it's a great witness, isn't it, to see how the government is looking at what you're doing and then actually not wanting just to support it, but even to duplicate it and follow your example. Really wonderful. I wonder if we could just move to the COVID issue, because we all know that Singapore did incredibly well with COVID right at the beginning, very few cases. And then we heard of COVID getting into migrant worker populations and dormitories and so on. Could you tell us a little bit about the problem that COVID has created specifically in terms of illness for migrant workers and how you've been able to address that?
So the COVID situation was really very difficult. So we were doing well, and when the COVID spread to dormitories, it really spread like wildfire. So it was last year, and there were many lessons learned. We were much humbled because cases were reaching 1,000 a day, and in our context was very high, and because they live in close quarters. But in a very strange way, COVID has resulted in tremendous public awareness of migrant workers. And, the public then had their eyes open to the living conditions, which for years we have been trying to tell the government, hey, look, or the public that, hey, they're really cramped, in all this, in the high-rise, complexes where there are about up to 7,000 to 8,000 people in one complex, 12 persons to a room, in double-decker beds. And so COVID spread. And so with that, we were able, thank God, that the measures came in very quickly and swiftly. However, it did not come without cost. I think the mental health cost of isolating a migrant population from the general population, because that spread was within the dormitories were sealed, lockdown. There was a very strict movement, restriction of movement, no mixing between the migrant community and the public. Now that raised concerns from social groups. Again, that gave us opportunity to respond. So groups started giving food, and our folks went down to quarantine centers. We were helping out with government quarantine centers in the dormitories. And it was a time where we were able to go into the margins where no one else wanted to go, so to speak. And our young doctors, many of them who have gone through the health serve program and who knew about us, who are volunteers, they were the ones who were coming up with the most creative response to COVID. From haircuts to health education to translation projects, just amazing. So yes, we did, in terms of the COVID response, the whole range of responses.
How vulnerable were the migrant communities specifically to COVID? One would imagine a lot would be of a younger working age, but at the same time, I guess there would be a high level of comorbidities as well. So
yeah.
were they a vulnerable population?
Well, the migrant workers we have in Singapore are largely younger men. Okay. And the domestic workers are younger ladies, right? So with this age group, we were very fortunate that, in this age group, they had fewer comorbidities, right? And so they were pretty okay. However, the problem was mental health. They did pretty well. For the migrant workers who were down with COVID, most recovered. And there was one who was in ICU for, I think it was a month or more, a very serious case, but even he recovered. And the whole nation, I remember, was rejoicing because he walked out of the hospital. That was early on, and our guys at the National Infectious Disease Control Center did a wonderful job. And then, you see, we gave the migrant worker the best care. And that was a real testimony to, the whole nation wanting to do the best for those serving at the fringe of society.
Yes, so it wasn't so much the medical complications of COVID, much more the issues of isolation, quarantine, mental health problems that particularly affected them.
Yeah, so mental health, quarantine was the main issue. And of course, I mentioned earlier in one of the slides that one of the quarantine centers were cruise ships. Cruise liners were used as quarantine centers. So we had migrant workers who were unfortunate to get the inside cabins, luxurious but windowless. So can you imagine being cooped up for a month without windows?
Yeah.
So we had our volunteers go in to run exercise programs, mental health exercises with them. And, the Lord, in his perfect timing, we had set up our mental health team 6 months before COVID hit. And so when COVID hit, we were sort of half ready with our mental health team. And so today, come July, we've just begin an official mental health team that has been funded partly by the government. The first time that funding comes from government, they gave us a substantial grant to fund the training for counselors. And Samaritans of Singapore, SOS, Samaritans of Singapore is doing all the training, and that's also then funded by the government.
Wonderful. So the Lord was actually preparing you for this, even without your knowledge before it happened.
Absolutely. Yes.
Now, Wei-Leong, in many ways, health serve is a best practice model, perhaps even globally in caring for migrant workers, which is why we asked you to speak on this subject. But any word of advice you have for people in other countries, other cultural contexts who are interested in engaging much better with the migrant worker population? What advice would you have?
Wow, this will take another webinar, right? I think. Well, I think basically we have, as Christians, I think we need to know who we are and what we are about. I think for most of our Christian volunteers, I think to know that we are Christ's ambassadors and that, our role, our vocation as Christian medical professionals is for the flourishing and thriving of others. It's not for ourselves, right? As medical doctors and medical practitioners, Our role is for the health and thriving of the migrant workers or anyone else for that matter. And how does it look like in our context? And then we'll have to then, think about it locally. So I think every situation is different, but I think the key is to know, have our identity in Christ, and then knowing, so love God, love neighbor. And we have that, you can be assured that you'll come up with the most creative, sometimes most audacious, creative ideas for Jesus, to love those at the fringe.
Lovely. And we've run out of time very sadly, but I just wanted to ask you in closing, you're clearly a visionary, you're a pioneer, and you're great relationally in terms of getting others on board and inspiring them with a vision. But there must have been real difficulties in this work as well. What is it that's kept you going throughout all these years, these 15 years of developing HealthServe and then through the pandemic?
Wow, there's so many things that have spurred me on. I think perhaps one of the most endearing one is relational. To have relationships, to have friends, and now many brothers in Christ who are once our beneficiaries. And I think to have friends, it's incredible to have friends who are, right on top of the social ladder, and at the same time have real brothers and sisters and friends who are the migrant workers of the world, and I think that's a tremendous privilege. And to hear their stories, to be a part of their stories, to learn from them, and to be fellow pilgrims is a tremendous privilege, and I count it a real joy.
Thank you very much. And of course, reminded in just what you said then that the joy of the Lord is our strength, isn't it? And
absolutely,
be able to, on the one hand, speak truth to power and enter the corridors of power, but on the other hand, relate to those at the lowest levels of society is the model that the Lord Jesus sent for us. So thank you so much for inspiring us with your story and challenging us too about our own local situations as well. Sadly, we've run out of time, but we've been listening to Dr. Wei-Leong Go, who is, I should add, the ICMDA Regional Secretary for Southeast Asia, in addition to all these other things that he does on the subject of serving migrant workers. And so it just remains to me to say thank you again, Dr. Wei-Leong, for your time and your example and your teaching to us and your inspiration. Thank you to Josh doing his IT wizardry behind the scenes, to our team of 4 translators, Schaefer, Daniel, Marie, and Hernda, for all your work that you've done. We rely very much on volunteers here at ICMDA too. And thank you finally to all of you for coming along and listening today. We hope we'll see you again soon on ICMDA webinars. God bless you.